Hi guys, this is Alicia with Good Morning Sunshine. It is now week 5, day 22. We have day 23 tomorrow. We had 4 lectures today. We started pharmacology, and then we got into the abdominal exam, and then we ended with something, but I'll get to that because I don't remember the last thing we learned. But we have all new information getting thrown at us again for probably the next exam in 2 weeks. So lots of stuff. But at least we got out early today, so I had time to eat. I had time to actually kind of take a nap. But yeah, prepping for tomorrow as of right now. But yeah, so I'm going to start with pharmacology. So what is a drug? So we're to start with that. Our objectives is to define a drug, to differentiate between FDA-approved, generic, and compounded drugs. These includes in prescriptions and controlled drug substances. And then we also have to define dosage, and dose regimen, and define pharmacokinetics, pharmacodynamics, pharmacogenomics, and define toxic drug effects and side effects. So what is a drug? Let's get back to that question. Well, it's a substance intended for use in diagnosis, cure, treatment, or prevention of a disease. It is used in humans or animals. It's a substance with a physiological effect when introduced into the body. So some of these drugs include, we have FDA approved, proprietary formulations. These are brand name drugs. Then we have FDA approved generic formulations, and then we have compounded drugs. But what is the difference between all these? This is what I'm going to go over with you. So starting with, we have FDA approved proprietary drugs. This demonstrates safety and efficiency in accordance with federally mandated good laboratory practices. Active ingredient and product were manufactured under good manufacturing practices in the FDA inspected facilities. Therapeutic consistency, product quality, and accurate drug shelf life, and scientifically substantiated labeling are all federally mandated. So everything is federally mandated in these drugs. This usually takes about 7 years, she said, for animal drugs, but for actually human drugs, it takes about 20 to 30 years. So that's why a lot of animal drugs are not FDA approved. But these drugs have 3 different names. We have to know, in our practices going on as vets, we have to know the generic name as well as the brand name. So brand name like Rimadyl, but its generic name is carprofen. So we would have to know both of those. Proprietary drugs, their name needs to be capitalized. However, their generic names then need to be in lowercase, unless it's at the beginning of a sentence. So steps for approval of a veterinary drug. Well, the drug concept is formed, has indication and species listed. There's an investigational new animal drug number assigned to it. Then the dosage regimen is determined. There's a target animal safety, so it's given once a day, 3 times a day, 5 times a day for 30, 60, 90 days. The effectiveness, so field trial on subjects with the disease. There's human food safety, there's chemistry, manufacturing controls, there's environmental impact, so dogs, because dogs or animals secrete usually and outside, and they want to see how that affects the environment. And then NADA, which is the new animal drug application number. These are usually listed on the, this is always, I should say, listed on the box or label. Because counterfeits, we'll talk about that too, usually do not have this number. So cost of FDA approval. For veterinary drugs, it's about $100 million, and like I said, it takes about 7 years. For human drugs, it's about $2.5 billion, and takes about 20 to 30 years. So we also got into steps for human drug approval. You have to have the concept, the animal studies, the an ID number assigned. The clinical trials, you have to go through phase 1, phase 2, and phase 3. Phase 1 being the healthy human volunteers, about 20 to 80 of these. Phase 2, you have to go through the safety and efficiency of subjects with the disease to be treated, about 100 or hundreds it says. Phase 3, safety and efficiency in subjects with disease, heterogeneous population, other drug treatments. So thousands. And NDA submitted, reviewed, labeling determined, facilities inspected, and NDA approved. So human and veterinary drugs, there's post-marketing surveillance, reporting of adverse effects to the FDA by patients and owners. You can tell MDs, DVMs, drug companies. This is crucial to this process. If an adverse event has an incidence of 0.001% and the phase 3 field trial had 2,000 subjects, so 2 subjects would show signs out of those 2,000 subjects. But if once we start marketing this drug, out of 2 million subjects, 2,000 subjects would show signs. So if the sign is like mild tachycardia, who really cares about that? But if death, people care. People care if that happens. All this information can be found on the drug label package itself. FDA drugs can be prescription or over the counter as well. And some human drugs can be used in animals and some cannot. Some are actually very dangerous for your pet. And we need to know the difference and educate the owners on these differences. So we'll learn all about that. It is the veterinary responsibility for the diagnosis, for the drug knowledge, for the drug law knowledge, understanding a benefit to risk factor, the proper justification and documentation, the veterinary client-patient relationship. This is called the VCPR, and then protection of the public. So the VCPR, that means that the vet has examined the animal, developed a preliminary diagnosis, and determined the need for the drug. So then we got into COVID-19, like the VCPR with COVID-19, and we got a quote here, and it says, in order to help veterinarians utilize telemedicine to address animal health needs during the COVID-19 pandemic, the FDA generally does not intend to enforce the animal examination and premises visit portion of the VCPR. I think this is crazy, but it will allow veterinarians to prescribe drugs without direct examination of their patients, which will limit human-to-human interaction and potential spread of COVID-19 in the community. However, I know we're letting people back in the building. We started when I left there, and we were still seeing the animal. There's ways around having human-human contact, so that's crazy to me. But anyways, so there's Schedule 1 to 5. Schedule 1 being the most potential for abuse of a drug, is used the least as medical use, and then we have Schedule 5, which has the lowest potential for abuse, and it is the most often used. So now we're going to talk about generic drugs. They are FDA approved. They have a different number called an ANADA instead of an NADA. It is abbreviated, but this number is equivalent to a proprietary drug. Like, it's still FDA approved. What is the bioequivalence? It has the same API at the same concentration and in the same dose form. It's equivalent pharmacokinetics and efficiency as the proprietary drug. But what's the difference between them? Well, cost. Generic drugs are sometimes cheaper, and then the inactive ingredients. It may make drug more or less tolerable depending on the person or animal. API is sometimes referred to as a generic name of drug. So remember, we have Rimadyl, which the counterpart, generic part is carprofen. We also have carprofen chewable tablets. But yeah, it's a generic drug of Rimadyl. Again, can still be prescription or over-the-counter. Generic drugs can. They still require all aspects of the veterinary responsibility. So like I said, the diagnosis, the drug knowledge, the drug law knowledge, understanding of benefit to risk, proper justification and documentation, and the VCPR and the protection of the public. Veterinarians are still in charge of all of that with generic drugs. Lastly, we have the compounded drugs. These drugs have not been tested for bioequivalency, efficiency, safety, strength, or quality. The active ingredients may not be manufactured under GMP or FDA-approved federally inspected plants. Again, not approved by the FDA. However, there's a lot of use with compounded drugs. Just know your knowledge, know where you're getting it from, make sure it's the correct drug, like they're making it right. Just do your background research. So basically the definition of a compounded drug is the manipulation of a drug other than in accordance with the FDA approved label to make a different formulation of the drug to meet the needs of a specific patient. So examples of compounding would include mixing two injectable drugs together, creating oral suspension from crushed tablets or injectable solution, adding flavoring to a commercially available drug, changing the concentration of a drug to fit the size of the patient. So there are real reasons to use compounded drugs or to make compounded drugs. So compounding is a common practice in veterinary medicine. Like I said, it's very hard to have FDA-approved drugs in veterinary medicine just because of how long it takes and how much it costs. Has lack of approved formulation, has lack of convenient and palatable administration forms. So use it wisely. Also can still be prescription or over-the-counter. However, they still require all aspects of veterinary responsibility. All the aspects I've listed, it's still on the veterinarian when prescribing these drugs. So then we have counterfeit drugs. We want to beware and warn clients about these. So I'm going to show you one of these is counterfeit. If you can guess which one, because remember I told you counterfeit usually does not have an NADA number. So this one does have an NADA number. I know you probably can't see it, but this is the actual drug. This is the counterfeit. They actually look pretty damn close to each other. So you have to really look at the drugs you're getting. They are marketed but not approved. The National Drug Code numbers assigned to all human approved drugs. Just because a drug marketed for an animal has an NDC code, it does not mean it's FDA approved for animals. This such as like aspirin. So then we got what is a dose, a dosage, and a dosage regimen. She said she gets annoyed if people get these confused, so we have to learn these really well. So a dose is the quantity of a medicine or drug taken at a particular time. So this would be the total milligrams or milligrams per kg, whereas dosage is a quantity and frequency of a dose of a medicine or drug, so how you're giving it, so milligrams per kilogram per day, or milligrams per kilograms every 12 hours, twice daily, BID, BID meaning twice a day, so any of those. So it's not the total dose, but it's the dosage you're giving that patient. And then we have the dosage regimen, which includes the route of administration and duration of dosing. So includes route. Is it a shot? Is it orally? You know, all of those things. So mg per k intravenously, like IV, every 12 hours for 7 days. So that's your dosage regimen. So what is not a dosage or dosage regimen? So not 2 tablets. Tablets come in different sizes. Not 3 mils. Injectable solutions come in different concentrations. So why does this matter? We got into definitions of pharmacodynamics, PD, which is the study of physiological effects of drugs and the mechanism of action. So basically what a drug does to the body. And then we got into pharmacokinetics, which is PK. It's absorption, distribution, metabolism, and excretion. It's what the body does to a drug. And then pharmacogenomics is the study of how genes affect responses to drugs. So like certain breeds can't have certain drugs, or they're more prone to, like in collies, some drugs like ivermectin go straight to the brain, so they really can't have ivermectin. And then a horse's ivermectin is a very high dose. You do not give this to yourself. Do not give this to a dog. You could kill them. So, and then we got into chemotherapy, which is the effect of drugs upon microorganisms, parasites, and neoplastic cells living and multiplying in a living organism. Sorry about that, guys. My alarm decided to turn on, and apparently that turns off the video. But anyways, so we were talking about chemotherapy drugs. Usually we know these as cancer therapy drugs, but they're also used in antibacterial, antiviral, antifungal drugs, and antiparasitic drugs. Toxicology is the study of the undesirable effects of chemicals on living systems. And then we got into toxic effects, are always undesirable. They result from excessive pharmacological action of a drug due to overdose or prolonged usage. Dose dependent, delayed, chronic, may still occur in patients at therapeutic doses. This is called idiosyncratic, and probably is related to pharmacogenomics. Side effects. So drug action outside the desired site may be good or bad. And then we got more definitions. We got the terms adverse drug reaction and adverse drug effect are often used interchangeably. However, an adverse reaction relates to the change in the patient, and adverse effect relates to the effect of the drug. An adverse drug event, however, should be considered separate from the latter terms, because it defines an adverse outcome that occurs while a patient is on the drug. So if you were drinking, but you also took this drug and you threw up, technically you have to tell you were on this drug. However, it may have not been the cause. It was probably the drinking that caused you to throw up, but you have to tell people that you were on this drug and you threw up on it. Causality has not been determined, may or may not be related to the drug, again, being administered. So then that was our first lecture. She also taught our second lecture. We got into the introduction to pharmacodynamics. Our objectives here was the introduction to dose response curves, pharmacodynamics definition, receptor types, receptor interactions like affinity, selectivity, activity, and potency, physiochemical properties of drugs that affect receptor concentrations. So first we got into the dose response curve. For most drugs, it's the magnitude of pharmacological response is proportionally related to the drug concentration at the tissue receptor site. So like as you give me more drug, you will get more of a response. So the relationship among log plasma or tissue drug concentration and dose and response generally can be considered a linear. Within the concentrations used therapeutically, ideally, plasma drug concentration will fall within the therapeutic range. And throughout most of the dosing interval, a representative concentration versus response curve generally yields a sigmoidal shape, which is that meaning an S-shaped. At lower and higher concentrations, larger dose increases are required to stimulate a response. Therapeutic doses should target the linear portion of the curve between 20% and 80% of the maximal effect. Above that point, increasingly larger doses again are needed to generate a change in response, and the risk of toxicity increases, although the dosing interval may be prolonged for safe drugs. So basically, I'm going to show you the dose response curve continue to this is basically what it looks like. So here on the blue, you have the therapeutic effect. In the middle, you have a toxic effect, and at the end, you have the lethal effect. So that's when the patient's like dead. The green's where it becomes toxic, and blue being therapeutic. So basically, they do these 50%. You have ED 50, which is the effective dose in the 50% of the population. That's the blue. You have the toxic dose in 50% of the population, which is in green. And then you have the LD 50, which is the lethal dose in 50% of a population. So the closer these are together, between the therapeutic effect and the toxic effect, is bad. You want them to be basically as far apart as possible. So basically we want a higher therapeutic number. This meaning that the drug is safest when it's when you have a higher therapeutic number. The therapeutic number, again, you would divide the TD 50 by the ED 50. So, you want this number to be high. Like I said, if those lines are close together, that's bad, because then you'd have a low therapeutic number. So let's say your ED 50 is 8 milligrams at a therapeutic dose, but and then your toxic, your TD 50 is 80 milligrams. You would take the 80 milligrams divided by 8, because that's your therapeutic. So you would take toxic over your therapeutic, and that would equal 10. So the higher that number is better. So basically, she asked here what drug would be safest. Remember, I told you if these are closer, that's bad. So the safest one is going to be A. It's going to be that one right there, because they're further apart. That means you have a higher therapeutic number between your therapeutic and toxic relationship. So then we got into pharmacodynamics, how drugs produce effects in the body. They affect us biochemically and physiologically. And how does this work? The drug binds to a receptor. There's a change in physical property of the cell. Chemical or metabolical changes happen, and they do not create new cell effects or actions. Remember that the onset and duration of action is affected by pharmacokinetics, the route of administration, drug dosage. So then we got into drug receptors. They're proteins on or within the cell surface of the cytoplasm. They have a ligand, which is something that binds to a receptor. They have a signal molecule, which is endogenous substance or drug. Can be specific, sorry, I have problems with saying S's. Binding sites on receptors, and then you have other drug targets like enzymes. So different receptor types, we have the ion channel, which you open and close an ion channel. We have the GPCRs, which increase or decrease enzyme activity. Then we have the enzyme-linked receptors. Tyrosine kinase would be an example of this. And then we have intracellular receptors. And then we have the drug receptor interactions, receptor upregulation and downregulation, adaptive mechanisms that may affect clinical response. We have tachyphylaxis, which is acute tolerance. It's rapidly decreasing response to drug after only a few doses. And then we also have tolerance, which is decreasing response to repeating constant doses of a drug. Maybe pharmacokinetic or dynamic. So receptor binding effects, this includes, again, affinity, selectivity, potency, and efficiency. Affinity being the force of attraction between the drug and the receptor. High affinity drugs are harder to displace and they last longer. Selectivity, oh, she showed us a picture. So this is high affinity. There's cute little pictures. This is low affinity. Look at the chihuahua and the cat. So the high affinity would last longer, the kissing of the two Goldens. the low infinity, the Chihuahua's gonna get mad at this cat. So then we got into selectivity. This is the specificity of a drug for the target receptor binding. We have the S and S receptors. We have alpha 1 and 2, beta 1 and 2, and dopamine 1 and 2. So why is selectivity important? There's stronger effects on target receptors. There's fewer effects on unwanted receptors, basically side effects. Potency is not as the be-all, end-all. It's a comparative term. It describes the concentration of different drugs necessary to induce the same magnitude of response. So true or false? A more potent drug is a better drug. That is false. And then we got into efficiency, which is intrinsic activity. Needs to be high or have the best therapeutic defense. Its ability of the drug to have response. It's a complex relationship. There's drug concentration, receptor activation, cellular response. There's also agonist, antagonist, partial agonist, and inverse agonist. Agonist, you could think about this as a lock and key analogy. This receptor interaction results in activation. This is occupation theory. Magnitude of the response is proportional to the number of receptors occupied. I think I have things to show you here. Let me see. So this is an agonist receptor. I'm going to try to show you the video here. So you have your agonist here. This is your receptor. And the agonist binds to the receptor, which will have an effect. I'm going to try to show you all these if I can get it to work. So then we have partial agonist, which binds to a receptor, activates a receptor, but only results in a partial response. So maximum response is not observed. I think I can show you this one too. Give me a few seconds. So here we have the partial agonist receptor. So again, partial agonist receptor here. And then you'll have the effect. However, here you would have a partial effect and not a full effect. So then we have the antagonist, which drug interacts selectively with receptors, but it lacks intrinsic efficiency. It blocks or reduces the action of the agonist at the receptor. So I think I have this too. See here. Actually, I need to explain something first. So we have competitive and non-competitive antagonists. And competitive looks like the drug. It binds at the same site. Non-competitive, it binds somewhere else to the allosteric site. It changes from receptor conformation, so the agonist can't bind. So the first video I'm going to show you is the competitive antagonist, and the second one is going to be the non-competitive. Okay. So here's again the competitive. So you have your antagonist here this time and your receptor. Okay. So antagonist goes into the receptor sites. This is the agonist where, see, the antagonist is in the way, it's in the binding sites, so the agonist cannot bind to the receptor, so there's no effect there. Here is non-competitive. Here's the antagonist down here. Here's the receptor. It's going to bind to the side of the receptor here, changing the conformation. The agonist comes in. Obviously, you can't fit into the binding site because the antagonist changed the receptor conformation. So again, there will be no effect there either. So then we have reversible versus irreversible antagonists also. Reversible antagonists can be overcome. It binds to the receptor, the affinity, but can easily disassociate from the receptor. These are things such as H-bonds, van der Waals, all weak and reversible bonds. The agonists present at sufficiency high concentrations, which can therefore displace the antagonist. But then we have, which also decreases potency because a higher concentration is not necessary to induce the same response. The agonist is attached, but then it's outnumbered by the agonist. The antagonist is attached, but then it's outnumbered by the agonist, and then leaves. So then you also have irreversible, which is high affinity for the receptor and binds and stays. The antagonist binds and stays because it's covalent bonded to the receptor. So even being outnumbered by the agonist, it's stuck to the receptor, so it can't leave. So again, I'm going to show you videos. The first one being the reversible video, and then the second one being the irreversible. Let me see here. So, starting with the reversible, here we are. Here's the antagonist, here's the receptor. Antagonist binds to receptor. There's the agonist, remember, there's no effect there. However, we keep going, it brings in its people. Has more agonists. See? You're outnumbered, buddy. They telling him to get out of there. So then, of course, he says, excuse me, pardon me, goodbye. So he'll end up leaving the binding site of the receptor, and the agonist can then bind. And then there is an effect. And then the next video, this is the irreversible antagonist. So again, antagonist, receptor. Antagonist binds to the receptor. The agonist comes in. Obviously can't because the antagonist is there, so there's no effect. It tries to bring in other agonists like the other one. Again, it says you're outnumbered. Get out. However, this time the antagonist says can't. I'm covalently bonded to the receptor. So it stays with no effect there. And then the agonist says, okay, sorry to disturb you, and then they end up leaving. Okay. So hopefully that was a good demonstration of those. So then we got into antagonism, which is other types. We have chemical, we have physiological, and then pharmacokinetic. Chemical is a direct chemical relationship between two drugs, a weak acid and a weak base. Physiological, two drugs act in the same physiological system but act on different receptors or pathways. And then pharmacokinetic, one drug alters the response to another drug through changes in the disposition. And then we got into drug-receptor interactions. The basis for pharmacodynamics, drug must get to the receptor in order to have their effect. It requires good pharmacokinetics and requires certain physico-chemical properties of the drug. She said we'd talk about all this stuff later. But we did get into the physico-chemical properties. We have lipophility, which is how soluble a drug is in fats and oils. These drugs cross membranes easier and therefore can distribute to more spaces. They're intracellular, abscesses, and the central nervous system. Then we have hydrophilicity, how soluble a drug is in water. These drugs are confined to the plasma and the extracellular fluids. Then we have molecular weight. Smaller drugs distribute more widely. Most therapeutics fall in this range of the 400 to 500 Daltons, less than this. Exceptions would be the monoclonal antibodies. Then we have ionization, which is unionized nonpolar drugs distribute more widely, dependent on pH and pKa of the drug. Then we have plasmin protein binding, which weak acid drugs bind to albumin, decrease with inflammation, and then weak bases bind to alpha-1 acid glycoprotein, which increases with inflammation. Then we have other, which is the concentration gradient, higher concentration, more drugs for diffusion. So then that was the end of that lecture. So then we had a random lecture, the professor, I love him, but he didn't even know why he was there. He's like, I could have just showed you this in lab when we had it, like he usually does. So yeah, we watched Monty Python, like a clip, too, because we had nothing better to do. But he was there to talk about the general assessment for the abdominal examination, injections, and venipuncture. So basically we have a general assessment. We check death. We look at conformation, pliability, sensitivity to palpation, hernias, tumors, mammary masses, skin, hair abnormalities. This is our general assessment when we just look at the dog or animal. But then we have abdominal palpation. 1 to 2 hand techniques. We palpate in different positions. It takes time and practice. We usually work caudal to cranial. We identify a landmark such as the bladder or colon. He said this is the first thing we're going to learn how to feel, because right now if we just feel a belly, we're just going to feel like intestines or gut, mushiness. But the structures that are routinely palpated are the urinary bladder, the colon, the uterus, plus or minus femur male. The kidneys, in cats, both, but dogs, just the left kidney. And then also the small intestines, there's multiple loops of bowel, mid to cranial, abdominal cavity, the prostate in intact males, the spleen in most dogs and majority of cats, and the liver for small dogs and cats, and the edge of liver lobes just caudal to the ribs. And then we're going to go check the hind limbs. For general confirmation, we're going to watch the animal move. Are they weight-bearing, non-weight-bearing? We're going to palpate major muscle groups for symmetry and pain. Joints are evaluated, distal to proximal. We manipulate each joint without moving the portion of the leg more proximally. That's what that would look like. And then we have the popliteal lymph node, which we will be able to feel. He said it's one of the easier ones to feel, which I already knew because I did at work. It's located at the popliteal notch. You're going to press medial to lateral. You're going to locate the lymph node and not the musculature or fat. And then we have the inguinal lymph nodes, which are a bit harder to feel in dogs and cats. He said you probably won't feel them, but you'll know when they are enlarged. So this is feeling the popliteal lymph node. And then we have the pelvis. We're going to palpate the ilium and ischium. Ilium being, the top of your pelvis, then the ischium. Your tuber coccyx, which are both sides, and the greater truncator, which is in the femur. And then you're going to do for pain, asymmetry of the muscle mass. So this is how you feel your pelvis in an animal. And then we got into intramuscular injections, which I already know how to give. So this was fun. You could either do it standing, sternal, lateral, in small volumes, generally less than 5 mils, at a small gauge, a 22 to 25 gauge needle. You're going to aspirate before injection, and then you're going to massage the muscle afterwards. So there's different sites to give IM injections. You have your quadriceps site. So you locate the greater truncator of the femur, the straight patellar tendon, and the ventral aspect of the ilium. So I'm going to show you a couple pictures. So that's where you start out at. This is the muscle you're going to give the injection into. and then you're gonna poke. You're gonna aspirate, then poke, of course. But then we have the lumbar site. This is given by the spine. This is the most common used site because you have a bigger area in order to give the IM injection. So this is the tuber coxae in the back here, and then you go up to L2, and this is where you're gonna give it on either side. Do not hit the spine in the middle. This is how you're gonna hold for it. You can actually feel the muscles right there. The back muscles are actually very big. And then you're gonna give it. Aspirate, give. So then you have the femur muscle, this is the hamstring site. Again, there's 2 hamstring muscles, so it's saying do not put it in the middle here. If not, your drug's not gonna go in IM. And this is how you give it. This is how you give it that way. And then we got into venipuncture technique. You're using a 20 to 22 gauge needle. Again, needle bevel up. You insert at a 25 to 30 degree angle. You aspirate slowly, and you release occlusion. And then you withdraw the needle. So then we talked about the lateral cephalus, which I have done. Give medication samples, usually in lateral recumbency, standing or sitting. The stifle is extended, and then you roll caudal to cranial. So I'm going to show you. This is how you would hold in this. I don't know if you can see it, but the saphenous vein is right there. This is the back leg. So that's how you would hold. You'd hold like that too. Here you have the needle. Go in, you're gonna use this thumb because saphenous veins tend to be rolly, and you want to keep that vein in place. Yeah, so that was basically all we learned in that lecture. It was a very fast lecture, so he just thought it was really funny. Of course, this last lecture was with the really fast guy. He went through 1 billion slides. Wasn't the most fun information, but here we are. There were so many objectives. Basically, we're talking about the topography of the abdomen. Sorry, not abdomen. Who knows what that is? The abdomen of equine, so horse. So the right side of a horse, you basically have the base and body of cecum, the right ventral colon, the right dorsal colon, the liver, and the descending duodenum. On the left side, you have the left ventral and dorsal colons, you have the small colons, the duodenum, the spleen, the stomach, and the liver. So you want to be able to identify as many abdominal structures as possible. This was in our objectives. So then we got into the abdomen. Why do I keep saying that? The abdomen versus abdominal cavity. So the cavity extends further cranially and is separated by the diaphragm. It's much larger than the abdomen itself. Abdomen is from the last rib back. There's a little space. But he just wanted us to know how to tell the differences. The paralumbar fossa, there's similar boundaries in a horse and in a bovine. However, in a horse, it's very small compared to that of a bovine. So here's the tiny space here of the paralumbar fossa, and it's big right here. So it's more prominent in an ox than it is in a horse. So then we got into the abdominal wall, which is the layers of the lateral abdominal wall. Basically the same. Well-developed cutaneous trunci muscle and tunica, the ligamentum flavor. You have the fiber. Direction is important. To identify the layer and cut into the direction of the fibers. Do not cross. It has peritoneal fat. So, let's see. I'm going to show you the retroperitoneal fat. It's all yellow. Look at that. It's very yummy. Ugh. So much fat. So then we got into prepubic tendon. which is located, I'll show you right there. You see the purple box right there? And this is where the abdominal muscles insert. Then we got into heaves, the heave line, which is hypertrophy of the external abdominal oblique muscle. So here's where heave occurs, right there. All right, don't die. She does that after she drinks water, so. So then we got into the stomach. The equine stomach, of course, is simple and composite, meaning it contains glandular and non-glandular. So horses are hindgut fermenters, which takes place in the large intestines, whereas cattle are foregut fermenters, and it takes place in the stomach. The size of a horse's stomach is about 5 to 15 liters. And then it says, please don't over-distend when administering fluid via the nasogastric tube. We'll talk about why you go through the nose and not the esophagus. So parts of the stomach, we have cardiac, we have fundus, we have the cecus, which is a blind pouch at the esophageal. Nope, I'm just not gonna say it because I can't say it right now. Esophageal, there we go, opening. We have the body, we have the pyloric, we have the antrum, the canal, the pylorus. So I'm gonna show you this. This is basically what the stomach looks like. Here we go. So we have the body here, we have the fundus, we have the cecus, cecus, and then we have the cardia, and then the pylorus there. So on clinical exam, the stomach is inaccessible. It's because it presents in the thoracic cage, and the stomach is on the 3rd floor. So talking about the 1st floor being the bottom of the thoracic cage, is way up there. So horses rarely vomit. This is due to the esophagus coming in at an oblique angle to the stomach. The stomach also has a very good sphincter. And again, the stomach is far away from the abdominal muscles, so it's hard to contract like ours does to vomit. And then, like I said, the stomach can be reached by the stomach tube induced through the nostril. So then we got to talk about the greater omentum, which it is small in the horse compared to other animals. It's connected to the transverse colon. It's unique to the horse. The greater omentum is attached to the ventral surface, again, of the transverse colon. The attachment of the greater omentum to the transverse colon makes the identification of the latter easy during exploratory surgery. It's unique to the horse. Is the rhinosphinctic or the nephrosphlenctic ligament is part of the greater omentum. So here's the greater omentum in purple there, right here. So then we got into talking about the small intestines. The rule of thumb in all domesticated animals, it has a fixed viscera, include the descending duodenum, the transverse colon, the descending colon. The descending duodenum is dorsal in the right side of the abdomen. Has a short mesoduodenum, and it has the right lobe of the pancreas. The transverse colon passes from right to left side, cranial to cranial mesenteric artery. And the descending colon is dorsal on the left side of the abdomen. The small intestine is similar in other animals, but it is longer. The duodenum is 1 meter. It's horseshoe-like. The stomach and duodenum have a dorsal aspect. I'm going to show you here. This is what it looks like here. So again, this being the stomach, but then it has all the parts. It has the descending duodenum, it has the ascending duodenum, and then has a transverse. So that's all the parts like in a dog that we talked about. And then we got into the G-genum. It's about 22 meters. Is in the left dorsal part of the abdomen. Has the volvulus. Has the intussusception, the entrapment and incarceration into the epilogue foramen or tunica vaginalis. So here's the diadema turning into the G-genum. Duodenum here, G-genum. And then we got into ileum with an E, not an I. It's not a pelvic bone. It's firmer than the G-genum for rectal palpation. It has an ileocecal fold. The large intestine includes the cecum, which is a comma shape, is 1 meter to 40 liters. Has a base, body, apex, and 4 tengae. So here's that to show you. We have the body here, we have the base here, the apex here. There's that cecocolic fold, the right ventral column, the tinea, and the haustra. Cecum position, the base is partly in the right paralumbar fossa and is partially covered by the ribs. The ileum enters and the right ventricle colon leaves. The body, it sinks within the abdomen to lie on the floor between the ventral parts of the ascending colon. So here's what it looks like in a horse, or I can show you. So one, you have the base, sorry, you have the base of the cecum here. Then 2, you have the body coming in. And then 3, you have the apex of the cecum here. And then the right ventral colon is right here, in the middle between all of that. And there's like many pictures of the cecum position. There's a lot, so I'm not going to show you all of those. I think we got to the ascending of the great colon. So the cecum has mesenteric attachments, which is the ileocecal fold, the cecocolic fold, and the cecoduodenal ligament. So I can probably show you those. Here's that picture. So 1, you have the cecum, which is this. 2, you have the right ventral colon, which is 2 here. 3, you have the cecocolic fold, which is right here. And then you have the ileum, which is 4 right here. 5, you have the ileocecal fold, which is between the ileum and the cecum, which is right here. 6, you have the mesoileum, which is here. 7, you have the left ventral colon, which is right there. That's what it looks like. It looks very weird. And then we got to the ascending or great colon. Has the most significant changes. It's about 4 meters. It's a double U shape, and it starts at the cecocolic orifice and ends at the transverse colon. The ascending colon is the portion of the intestinal tract that undergoes the most significant changes from the simple tract of the carnivore to the complex tracts of the herbivores and omnivores. So then we got into the fixation of the ascending colon, the ascending mesocolon, which is also attached with the idiocolic ligament. Then the cecocolic fold is the ascending colon is not fixed, except its beginning at the base of the cecum and its end the transverse colon, but the ventral and dorsal colons are connected by a short intercolic ligament. So the descending small colon is small. It is because it's W-shaped. As saculation, it has a long descended mesocolon, and then it has 2 tinea. So I'll show you it's small compared to everything else in a horse. There's potential points of obstruction, where it is where diameter changes and where flexures occur. So there's many where the stars are. That's where obstruction can occur. And then we got into the liver of a horse. It is oriented obliquely, it is entirely under the ribs, and there's no gallbladder in equine. The liver is completely overlapping by the lung. It is often difficult to obtain a liver biopsy in a horse because of this overlap. Again, the liver is on the 3rd floor, so it's high up. It is right dorsal colon can push on the liver, causing liver atrophy. So the right colon is at the side here, and then there's the liver. The tuber cocci include the oil cranite and the point of the shoulder. The biopsy is performed in the area between the 2 lines between the 11th and 14th ribs of a horse, so in the 12th intercostal. Then the left lobe biopsy is in the 8th intercostal space. Then we got into the epiloic omental foramen, which I can show you here. It's this guy right here in the middle. And we got lots of pictures of those. But we actually got a laparoscopic view. So it's this right here. The HDL is the hepatoduodenal ligament. PV is the portal vein right here. And then CP is the conjugate process of the liver. Then we have the palpation of the epiloic foramen. It's on the right side. It's on the visceral surface of the liver. It's between the caudal vena cava and the caudate lobe of the liver dorsally, and portal vein, and the gastropancreatic fold ventrally. Then we got to antegrade incarnation. Again, the epiloic foramen is between 2 veins, the caudal vena cava and the caudate lobe of the liver dorsally, and the portal vein, and the gastropancreatic fold ventrally. But then we have retrograde incarceration. And then we have epiloic foramen entrapment, from left to right, tearing or pushing the greater. So then we got into the pancreas, which is a triangular shape. The body has 2 lobes, right and left. The body is perforated by the portal ring for portal vein. It's primarily positioned to the right, sublumbar and caudal to the stomach and liver. Extends to the right and left kidneys. Then the spleen is again triangular in shape. Its surfaces are parietal and visceral. Has a hilus. The base is ventral to the last 3 ribs. The caudal margin is convex, initially parallel to the costal arch of the ribs. Can be palpated per rectum. It's gastrosplenic ligament and suspensory ligament of the spleen. So the stomach and spleen are attached, which I learned I got that wrong on the last test, but they are attached. But also the left kidney is up there too. The stomach and spleen are attached together, and then there's also a left phrenosplenec ligament between the spleen and left kidney, also with a phrenosplenec ligament connecting the right or the left kidney and the spleen. Then I was talking about renal splenic entrapment. It gets trapped and closes colon. Sorry, the colon gets trapped between the spleen and the left kidney. And then we got into the urinary bladder. The equine kidneys, right has a heart-shaped. It contacts the conjugate lobe of the liver, and then the left kidney is bean-shaped. It's medial to the spleen. The adrenal glands are at medial cranial pole of the kidneys. The right is ventral to the last 3 ribs in the transverse processes of the lumbar 1 on the spine. Then the left is ventral to the last rib in transverse process of L1 to 3. So it's cloudy, it's turbid, and it's frothy urine in horses, and normal to the mucus glands in the renal pelvis and initial ureter. See how cloudy that is? So the kidney, adrenal glands, and adjacent organs, he shows us in different views. He shows us the pelvic cavity. He told us to look at all this stuff on our own, so we just get a general view of what everything looks like inside the stomach. I was going to see which picture was easier to show you. But here's this picture. I think this is a pretty good picture. I don't know if you guys can see it exactly. But here we have the liver. Then we have the stomach. Remember, this is the horse's back laying down, so it's upside down. Or laying on its back. So we have the liver, the stomach, the spleen. We have the jejunum. In pink here, we have the descending colon. We have the rectum, the uterus, bladder. And here we have the left ventricle colon, the left dorsal colon. We have the pelvic flexure there. So lots of parts, big parts too. But yeah, that was it. Lots of stuff. I have to combine my other video now. But we'll have more lectures tomorrow. Probably more information. But that's what I learned today in school. I still have to exercise. I probably have to exercise inside because it's currently pouring rain. Has been pouring rain since this morning. So I don't get to exercise out in nature today. So I'm very disappointed because I haven't exercised in a few days. And I kind of wanted to be outside and not on a treadmill. So we'll see how that goes. I love you guys and I thank you guys for watching.